the choice of the optimal donor for allogeneic stem cell transplantation in acute myeloid leukemia has been always a challenge. Historically, we mainly relied on the HLA identical sibling donors, brothers and sisters who are HLA compatible. Then progressively, thanks to the growth of the different registries, the use of unrelated donors, HLA matched unrelated donors, has expanded. But also for those patients lacking a fully matched donor, we had a mismatched donor. In parallel, we've seen for a certain time a huge development of cord blood activity, cord blood as a stem cell source. However, the cord blood source, the cord blood as a stem cell source has proven to be quite difficult in the adult setting because we do not have always enough cells. The immune recovery has been quite slow, although the long-term outcomes are rather good. In the last 5 to 6 years, we've seen a lot of enthusiasm and excitement about the use of haploidentical donors for allogeneic stem cell transplant. And I must admit that the haploidentical donor story is not a recent one. I mean, for more than 30 years, the transplant community was trying actually to perform successful allotransplant using haploidentical donors. However, we have been always faced with this dilemma of graft rejection versus severe acute GVHD, but also delayed immune recovery and fatal opportunistic infections. The use of haploidentical donors has been completely rejuvenated and made popular thanks to the introduction of the so-called post-Cy, which is about the use of high doses of cyclophosphamide after transplantation, after the infusion of the graft. So the graft is infused at day 0, and then cyclophosphamide is infused at day 3, day 4, or day 3, day 5, depending on the protocols. And what we have seen recently, thanks to the EBMT registry and the CIBMTR registry and different studies performed by different groups, when you compare the outcome of the patient who received the graft from a haploidentical donor to those patients who received it from a mismatched, unrelated donor, it's clear that the haploidentical donors are bringing some great added value and benefit for the patient. When you compare these haploidentical donors transplants to the outcome of a patient who received a transplant from matched unrelated donors, more and more, obviously we can discuss some fine details about the conditioning regimen, about the GVHD prophylaxis, about MRD status and so on. But the overall message is that haploidentical donors are allowing to achieve similar outcomes, if not better, in terms of GVHD control to what you can obtain with other stem cell sources. And I think this is really a crucial information, especially these days during the COVID-19 outbreak, where half of the planet is confined, borders are closed, So transport of the graft has been challenging. I know very well, I'm aware that different organizations, regulatory bodies are making an amazing, fantastic effort to allow grafts to travel and to reach the patient who are in need. But in general, it's probably easier in terms of logistic to rely on haploidentical donors in such special circumstances. So the overall message is that if a patient is in need of allo transplant, definitely haploidentical donors can provide a good solution with a good outcome and usually limited or I would say reasonable, let's say it, with a number of complications similar to what you would expect with other stem cell sources.